Siobhan Hall, and I will be presenting on the mental health needs in special populations that are often seen in primary care. Mental illness in older adults is significantly underdiagnosed because symptoms are often mistaken for normal aging. Depression and anxiety frequently present as somatic complaints, and suicide rates are the highest among older white males, largely due to isolation, chronic illnesses, and the loss of independence. Dementia is also a major contributor to disabilities and the healthcare costs. 20% of adults ages older than 65 have mental health disorders. Depression is prevalence is 8 to 16%, and this is even higher in nursing homes. And this has the highest suicide rates are in males that are over the age of 75. Assessment and screening. Assessment requires both mood and cognition evaluations. Evidence-based tools include the Geriatric Depression Scale, the PHQ-9 for depression, and the Mini-Cog and the MOCA, which helps detect cognitive impairment and dementia, while the confusion assessment method identifies delirium. According to the DSM-5 consideration, depression in older adults may present as fatigue, sleep disturbances, pain, or apathy rather than sadness. The medication review is very important and essential because polypharmacy commonly causes psychiatric symptoms in the elderly population. Older adults metabolize medication more slowly due to the decrease in the renal and hepatic clearances. SSRIs are the safest, but we must monitor sodium levels and the fall risk. Non-pharmacological therapy is extremely effective, especially behavior activation and structured outline. Treatment follows the principle start low and go slow because aging decreases renal and hepatic clearances. The pharmacological treatments should be sertraline or Lexapro. Avoid TCAs, and non-pharmacological are caregiver support, exercise programs, social engagements. And collaborative care can include PT and OT, neurology, social work, or caregiver education. Pregnancy does not protect against mental illness. In fact, hormonal changes and psychosocial stressors increase risk. Untreated depression is associated with poor prenatal care, substance use, and neonatal complications. Prenatal mental health conditions affect approximately 1 in 7 women. Postpartum depression occurs in about 10 to 15% of mothers, and suicide is the leading cause of maternal mortality. Untreated depression is associated with impaired infant bonding and premature births. Screening for bipolar disorder is critical because antidepressant monotherapy can trigger mania. The EPDS, which also stands for the Edinburgh Postnatal Depression Scale, is a recommended screening tool during pregnancy and postpartum visits. All patients must be screened for bipolar disorder prior to starting any antidepressants using the mood disorder questionnaire. And the DSM-5 includes the peripartum onset specifier for mood disorders. Treatment decisions weigh medication risk versus untreated illness risk. Sertraline is considered the first line due to minimal breast milk transfer and favorably safely for the mother and the baby. Psychotherapy, especially cognitive behavior therapy and interpersonal therapy, is highly effective, and care should be coordinated with obstetrics, pediatrics, and lactation specialists. 1 in 5 adolescents has a diagnosable mental health disorder, and suicide is the second leading cause of death in ages 10 to 14. ADHD has a prevalence between 9 and 11% in this population. Anxiety disorder are the most common, followed by ADHD and depression. Contributing factors include social media exposures, academic stresses, bullying, and family dynamics. Screening tools include the PHQA for depression, the GAD-7 for anxiety, and the Vanderbilt scale for ADHD. Suicide risk should be evaluated using the Columbia Suicide Severity Rating Scale. And adolescents should always be interviewed privately because they disclose sensitive information more accurately when their parents are not present. And the DSM-5 criteria recognizes that irritability may be the primary manifestation in depression in the youth. Fluoxetine is the first line in the SSRIs for pediatric depression. Providers must monitor closely for the suicide ideations due to the FDA black box warning. And ADHD is treated primarily with stimulant medications such as methylphenidate. And behavior therapy, school accommodations, and family therapy are essential components to treatment. The LGBT individuals experience significantly higher rates of depression, anxiety, substance use, and suicide attempts due to minority stress, discrimination, and stigmas. Transgender youth have particularly elevated suicide risk, 2 to 3 times higher depression and anxiety. They attempt suicide up to 40% higher in transgender youth. And healthcare avoidance is very common. Providers should use the patient's chosen names and pronouns and create a non-judgmental environment. Screening includes the PHQ-9, the GAD-7, and suicide risk assessments. Trauma and bullying should be assessed. DSM-5 recognizes gender dysphoria as distress related to gender incongruence, not the identity itself. Gender-affirming supportive care improves engagement and outcomes. Treatment includes standard psychiatric medication when indicated, affirmative psychotherapy, and the coordination with endocrinology for hormone therapy when appropriate. Social services resources significantly reduce suicide risk. Immigrants and migrant population frequently experiences traumas, displacement, financial stresses, and barriers to healthcare. Depression and PTSD rates are significantly higher than the general population, and fear of deportation often prevents seeking care. Assessments should be used culturally appropriate approaches. The DSM-5 cultural formulation interview helps understand beliefs about illnesses. Screening tools include translated PHQ-9 and the PTSD checklist. A trained interpreter should always be used instead of the family members. Trauma-informed care is essential. SSRIs such as sertraline or fluoxetine are the first-line treatments for depression and PTSD. Providers should also address social detriments of health and coordinate with community organizations, social services, and legal resources. Mental health disorders across the lifespan are frequently encountered in primary care. Each special population presents unique biological, developmental, and social considerations that affect both presentation and treatment. Using validated screening tools allows earlier identification and improved outcomes. Evidence-based management includes pharmacological therapy, psychosocial therapy, and interprofessional collaborations. By incorporating routine screenings, culturally sensitive care, and collaborative treatment planning, nurse practitioners can reduce disparities and significantly improve patients' quality of life. Thank you for your time, and I hope you enjoyed my presentation.